afternoon, everybody. Chris here. Wanted to take some time and talk with you about some upcoming clinical changes, additions to our protocols, and some new treatment guidelines we have coming out. First one's ketamine. We're going to be adding ketamine to your controlled substance inventory in our trucks in order to provide some different and better sedation, pain management, things of this type for our patients. I want to take some time to understand the mechanism of how ketamine works, know the indications and contraindications for ketamine use, understand how it's supplied now, how we're going to be putting it on the trucks, and understand that based on supply and demand and how we're able to get our medications, this can change sometimes. Understand the administration of ketamine, the Thorne protocols for usage, and review the documentation for use of ketamine as well as any other controlled substance. First of all, let's look at the mechanism of ketamine. Ketamine is an NMDA receptor antagonist. So what does all that mean? In the nerve synapses, the way sensations are transmitted from one place to the other, if you look in the area here, ketamine is responsible for creating a memory that's associated with pain or the feeling that is associated with pain. So the ketamine blocks the NMDA receptors from crossing the synapse and slowing down that process, thereby creating an analgesia and even sedation in some cases. So we got to be very careful with ketamine and understand that across the continuum as far as the brain's concerned, if we look at it like a big K and the top part is our graph, we have analgesia, recreational use, partial dissociation, and a dissociation, total dissociation after giving ketamine. We're going to be functioning the analgesial and partially and dissociated. The recreational drug, I put that on there so you know that ketamine is out there and about what dosages, according to most experts and pharmacists will tell you that 30 milligram range. Now, we're not going to be given medications in those dosages. That's just what kind of dosage would be to achieve that area on the spectrum as we're talking about ketamine. So what does ketamine look like? If we're talking about that early analgesia, everybody's seen this kid. You might have been this kid getting your wisdom teeth out. You're just kind of goofy and feeling it can give you a little bit of a euphoric feeling. All the way up through that totally dissociated. You know, you got Homer here, his eyes are rolled back, he's slobbering. He's just totally lost it at this point as far as his level of consciousness. So you got to be very careful with ketamine. Ketamine can work via its actions of blocking those receptor sites across a whole spectrum based on the amount we're giving. So ketamine is a drug that a lot of EMS agencies have had trouble getting their medical directors to sign on to, and the medical direction community as a whole has always been kind of afraid of ketamine. There's been a lot of bad things happen out west. You can read articles of where EMS professionals were even as far as charged based on misusing ketamine and causing patient fatality. So, you know, what happens if we go off script or we don't stick to using ketamine the way we're supposed to? We lose it. It's just like the sign here says, this is why we can't have nice things. It's why medical directors are hesitant. It's why safety with ketamine is a big concern. Lack of understanding causes those safety concerns and not following our protocols. So we're kind of going to take off here and review ketamine and look at what it is, how it works. We've talked about how it works. Ketamine, brand name is Ketalar. That's awful close to Ketalog, which is other medications that we may or may not carry at times. So we're going to stick with calling it ketamine. It's an analgesic, anesthetic, and sedative. Again, it's an NMDA receptor site antagonist, basically blocking the process of the input in the central nervous system. It blocks sensory. What are the indications? Moderate to severe pain when opioids are not working, sedation, and excited delirium. Now, this picture here shows ketamine in the way that we're currently getting it and currently carrying it. 500 milligrams in 10 milliliters. So that gives you 50 milligrams per milliliter. It is a class 3 medication and needs to be treated as such. Ketamine for pain, a rounded dose of 0.1 milligrams per kilogram, and we're going to look at this in depth in a second. Every 3 to 5 minutes is needed. Sedation, you're looking at 2 milligrams per kilogram, or 5 milligrams per kilogram if you have to give it IM. All right. Contraindications. Patients that are severely hypertensive, or looking like they're in some sort of a hypertensive crisis, we want to avoid ketamine. Hypersensitivity to it. Unfortunately, hypersensitivity, they may not know it because they've never had it before. So always be, with ketamine or any other medication we're given, always be ready to treat any anaphylactic or allergic reaction. Adverse reactions that can be seen with ketamine range from causing hypertension to dysrhythmias, tachycardia. You can get respiratory depression if given too fast or too much. That's why we'll give it weight-based. It does cause CNS depression, which it's supposed to, so keep that in mind. It can cause nausea and vomiting, so it's always a good idea to give it in conjunction with some Zofran. And you can get an emergence reaction, which an emergence reaction we'll talk about in a little bit. Interaction. Ketamine, it can and will interact with certain narcotics and benzos, other sedatives, and hypnotics by increasing the CNS depression that's already been caused by those drugs. That's why typically we're going to try our first dose of opioids first. If you feel like that's not going to work, you can always talk with the medical command. Ketamine is in your tools and bag of tricks for pain medicine, sedation, and excited delirium at this point. Typically, you'll see it supplied in 500 milligrams and 10 milliliters, which is what we're going to be carrying. If we change that because of supply and demand or because of our suppliers, we'll always, of course, let you know. 200 milligrams in 20 milliliters and 100 milligrams in 50. So those are the common ways that you see ketamine supplied. So when we look at ketamine, our dosing kind of follows exactly along this chart if you look at our protocols. For analgesic or pain medicine, we're going to give it 0.1 to 0.3 milligrams per kilogram of body weight, and that's going to be to a maximum dose of around 30 milligrams. On that K we were looking at earlier, that is that analgesic, lower end. You want to give it slow IV push. It's going to have a similar action and efficiency to opioids. Usually given properly and not too fast, you won't see any respiratory suppression. That's a good thing about ketamine. Not many contraindications. Always start low and work your way up with ketamine. It can be valuable, especially if you have a lot of these people that are not necessarily abusers, but they have a high tolerance to opiates because they've been on long-term pain management, things of this nature. Ketamine will become an excellent medication for them. For our sedations, 1 to 1.5 milligrams per kilogram. They need to be hemodynamically stable. You need to watch for any adverse reactions. All right, now we're not going to be using it in airway management right now. As far as you hear people talk about the K-hole, we don't want the partial dissociation, emergence reaction, bad trip kind of feeling, and ride people an hour to the hospital like this. If you have to redose, that's one thing, but we're not going to keep people in what you call the K-hole. I don't want to see that happening. I don't want to see that in your documentation. That's not the way it's to be used. Severe agitation, excited delirium, you're looking at 1 to 4 milligrams per kilogram with a maximum dosage of 300 milligrams. When you're given it this high, you do get into a situation of unplanned intubation because of airway issues. In some patients, you can get kind of the opposite effect and worsen the psychosis. So you've got to be on guard with this, maintain your scene safety, and protect yourself at all times. Anytime you're given ketamine, of course, you need to realize that watch out for laryngospasm. You could get some elevated secretions, and you can have blood pressure and heart rate changes depending on how that patient is going to respond to the ketamine. So how are we going to give it? How are we going to use it in our protocols? Rule number one, first and foremost, ketamine requires online medical command before any administration. I'm going to say it again for the people in the back, before any administration. Pain management, adult dose, like I said, 0.1 to 3 milligrams per kilogram, pediatric 0.1 to 0.2. If you're using it for sedation, again, 1 to 2 milligrams per kilogram, we're going to start on that low end. Now, there is an exception. The only exception to the medical command rule is you may use ketamine for excited delirium without online medical command, secondary to Versed, if you believe that there is a safety issue for the crew, the patient, or others. That's for excited delirium only. Anything else, you must have online medical command. And that's going to be 2 milligrams per kilogram, no more than 4 milligrams per kilogram, to a maximum dosage of 300 milligrams. Treat this stuff responsibly. Give this stuff in accordance with our protocols, and always watch your patients for any changes like you would any medication. But keep in mind, ketamine is new. If you haven't used it before, be on the lookout for CNS depression, secretions in the airway, any airway problems. Further rules for ketamine: do not use ketamine, and for that matter, any other of our controlled substances, without a blood pressure every 5 minutes, continuous SpO2, continuous end-tidal monitoring, a documented pain scale, a documented Glasgow Coma scale. All of these are things we should be doing anyhow, and a documented sedation scale. We'll make sure we get these laminated up and placed in the trucks prior to ketamine, post-ketamine, and arrival at the facility. Well, I've never used a sedation scale before. So we'll use the Richmond Agitation Sedation Scale, or you call it a RASS scale. You're simply looking and scoring here based on your patient. Before you give ketamine, they're a very painful person. They're having a lot of pain, but yet they're still alert and calm. So you can give them, a 0. And 0 is where you want to be. That's a normal, everyday person. Now, you've given them the ketamine for pain, and all of a sudden they get a little tiny bit drowsy, or maybe it's a small frame person, and you start seeing some light sedation. So you would scale them. You would just document a RASS score of -1 or -2. And then when you get to the hospital, maybe it's worn off and they're back to a 0. So that's just a constant continuum of where they are on a measurable scale as far as how much sedation or CNS depression, if you want to call it that the ketamine is providing. On the other hand, your excited delirium, pulls, moves, tubes, catheters, if they're aggressive or they're showing aggressive behavior, you would score them at a +3. Same thing up here if they're combative. Or this shows, using this scale is a good way to show that there was a need for that level of urgent sedation for a patient. All right, and then of course you'll do your pre, post, and arrival at the hospital. Again, just as a reminder, same controlled substance medication record. You'll check ketamine. Got to have that run number. Got to have that concentration and how much we gave. Got to fill out your administration section. Amount wasted. Now, with this ketamine, you will generally, unless you have a very large patient, you're going to have some waste. Treat it properly. Make sure you're documented properly. You have to have a certifying physician sign this. Why? And people are saying that doctors are giving a static about not wanting to sign because of standing order. It's not a standing order. You have to have online medical control for anything except the excited delirium. So you're going to have had a doctor tell you that it's okay. So we'll use this form for any and all of our ketamine, again, morphine, fentanyl, Versed, any of those administrations will use the same form. So I would urge you to look back over this presentation often if you don't give ketamine for a while. Treat it responsibly. Know your indications and contraindications. Account for it properly. And treat it like you would any of our other controlled substances. If you have any questions, contact your supervisor, your market manager, or reach out and email me, and we'll get you answers to these. So, like I say, use it with caution, be responsible, and thank you.